Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Jazz Pharmaceuticals, Inc.
Welcome to a quick talk on small cell lung cancer, what community clinicians need to know. I'm Dr. Jacob Sands, Associate Chief of the Lowe Center for Thoracic Oncology at Dana-Farber Cancer Institute and Assistant Professor of Medicine from Harvard Medical School. And I am so excited to be joined today by Dr. Misty Shields, Assistant Professor of Medicine at Indiana University School of Medicine at the Indiana University Simon Comprehensive Cancer Center. Welcome, Misty.
Thank you, Jacob, and happy to be here.
For the next 15 minutes, we're going to do a rapid fire program where we'll have 90 seconds to address specific topics, focusing on the care of patients with small cell lung cancer. Misty, let's jump in. First, let's talk about the clinical impact of small cell lung cancer. So, the aggressive nature, rapid progression, high symptom burden. What do you think are important points around this?
So important. So, patients with small cell lung cancer may have a, really aggressive onset of symptoms quite early. It's not uncommon for us to see patients with small cell lung cancer in the emergency room where they were fine a month or two before and maybe have a pneumonia that won't go away or a cough that persists that continues to get worse and worse where they need urgent intervention. And so patients with small cell lung cancer may have a chest x-ray or scan just a few months prior that was completely normal. What we know about small cells, it's rapid growing and it can cause a lot of symptoms, either symptoms due to where the tumor is located, the tumor burden either in the chest or in another organ that's causing pain or symptoms, or something that is called a paraneoplastic syndrome, which is the hormones that the small cell is releasing that causes other symptoms like Lambert-Eaton, which might be a significant weakness that might end a patient up in the ICU due to burdens. So it can be quick. It's important to recognize, important to diagnose, and important to treat quickly with importance for patient care and goals of care really at the forefront.
Yeah, and even someone with a lot of symptoms, poor functional status from the disease, metastatic disease, really important to consider treatment in those patients because it can get a lot better. All right,
Yes, absolutely.
let's jump on to the next one.
So, Jacob, what are the stages of small cell lung cancer? What does it mean? How is that different than, let's say, non small cell or other lung cancers? And does that impact treatment and how, prognosis that we might be talking to patients about?
Yeah, so with small cell lung cancer, of course, there's still stage 1 to 4, but we often talk about it in limited stage and extensive stage. And the difference between those is essentially, can the full amount of disease seen on scan be incorporated in one radiation field? So ultimately, the radiation oncologist ends up being the determinant of that line. And it's a bit of a gray area as far as can it be safely incorporated into one radiation field. Now, if it is limited stage, then treatment with chemo and radiation with curative intent is the treatment. And we now have the Adriatic data, which shows that 2 years of durvalumab after the chemo radiation improved survival, improved progression free survival by 7.5 months, improved median overall survival by 22 and a half months. So, really important to incorporate durvalumab after the chemo radiation. Now, for very limited stage disease, solitary lung nodule, surgical resection, I think is still an important consideration. And then adjuvant platinum etoposide. We do have a clinical trial that is opening right now. It'll be at some centers that'll be cisplatin etoposide and durvalumab as adjuvant therapy. Extensive stage setting, carboplatin etoposide and either atezolizumab or durvalumab. And of course, you have to consider the Mforte data, which is atezo plus lurbinectedin maintenance. And I'm sure we'll get into that a little bit more because I know I've gone over on time on that one. So for the next one, what are the common presenting symptoms? You discussed this a little bit, and red flags, things like cough, dyspnea, weight loss, paraneoplastic syndromes. You kind of touched on those so far, but what should primary care and be looking for?
Yeah. So, when we think about patients with lung cancer, really, this is why the ribbon for lung cancer is white. It's really a clear ribbon for symptoms that are silent. And so, for so many of our patients with lung cancer, they may not have any presenting symptoms until they have all presenting symptoms. And so, it may be the most common symptom for patients is a cough, but it may be other symptoms like unintentional weight loss, back pain that just won't go away despite Tylenol or ibuprofen, or it may be, unfortunately, hemoptysis coughing up blood. And so, you know, as mentioned, some patients do have other presenting symptoms like weakness. Maybe they have lab abnormalities like low sodium, despite all efforts to make sure that the patient is well hydrated. They have no kidney dysfunction, no other endocrine issues. It may be that we see hyponatremia with SIADH, leading this lab abnormality. And so, really the most common presenting symptom is a cough, but it's important to look for other red flags, that it won't go away despite antibiotics, that patients may have other, kind of B symptoms that are associated with it. And, really, it's important to get a scan and evaluate it and figure out the cause, as we all do as physicians when we have patients that come in with a new, chief complaint, that we want to make sure we know the reason and that patients are feeling better. And so, if there's a mass on these x rays, you've got to go and figure out what that is so that you can help the patient. All right. So, Dr. Sands, how do we identify some of the challenges with the diagnosis of small cell lung cancer? Things like staging, getting a timely diagnosis. How do we tease this out from other symptoms? And also, how do we address the stigma that has surrounded this disease for far too long?
Well, the stigma I'll address first. I think this is a really important thing. Far too often, people speak of like the smoking history, and I think, um, and there's a stigma around that. I'd really encourage physicians when you're addressing this with patients around smoking, is to not just do the easy thing and be like, "You need to quit," or "This is just because of smoking," and say, have some compassion and have some empathy around the fact that these people are addicted to cigarettes. Now, I've also had patients that are like, "Look, don't talk to me about it because I wanna smoke, I like it," and, okay, I get I'm not mad at them, this is kind of just part of that, and I recognize that that might be harder to understand, but when you're placing a lot of blame on patients, it actually makes it harder for them to quit, because when people are feeling that, anger at themselves or these negative emotions for many years, smoking is how they've, handled that in some fashion, so helping people to not feel so guilty about that, I do think is important. Now, in the initial diagnosis, time is of the essence for small cell lung cancer. And so if someone comes into the hospital with symptoms, you need to start their treatment in the hospital. That means if you have a high suspicion about small cell lung cancer, when you get that when you get that biopsy, you're talking with pathology and saying, "Hey, does this look like small cell?" At the same time, someone who has a lung nodule, then you're working on getting that biopsy to recognize early to be able to treat as well, because a long delay can result in long spread, a widespread of the disease. All right, next question. What are the current and emerging treatment strategies, especially looking at combinations? And what do you think is going to redefine standard of care and why? This is a tough question because there's a lot going on. So 90 seconds, Misty, the challenge is on here.
Yeah, a lot to unpack here. So, as mentioned, in May of 2024, we saw the Adriatic data setting the new standard of care for limited stage concurrent chemoradiation if the patient is fit, followed by the adjuvant or consolidated durvalumab once a month for 2 years, permitting no progression and tolerable AEs. With the first line strategy has been chemoimmunotherapy since 2018 when we saw the data from Empower 133, leading to a 5-year survival with the Umbrella A extension study of 12% at 5 years, 11% at 6 years. Durable response in a subset of patients. We saw in Forte this last year at ASCO, now showing a new standard of care for maintenance strategies with the addition of lurbinectedin to atezolizumab in the maintenance setting, improving both progression-free and overall survival. We saw the second line data with tarlatamab, with really showing that this Delphi 304, that uh, there's no other contender for the second line for patients. And so that DLL3 CD3 bispecific T cell engager improves survival over traditional chemotherapy like topotecan. And I think, there are more strategies coming with antibody drug conjugates, radioligands, radiopharmaceuticals, and how early should we be implementing all these strategies? I think there's a lot of trials. We should be looking for trials for our patients anytime we see a patient in clinic with small cell lung cancer.
Misty, I'm going to challenge you. I know I'm taking us over the time, but within the next couple of years, we're going to see Delphi 305. This is tarlatamab plus durvalumab in the maintenance setting. If we compare that to Forte, which we already have the data for, as you mentioned, atezolizumab plus lurbinectedin, what do you anticipate as the first line maintenance standard of care in a couple years? What do you think is coming?
Yeah, so we saw the phase 1 of this study and, 25 months median overall survival regardless of the IO backbone Atezo or Durva used. Unprecedented. If the phase 3 shakes out, which we suspect it will, this is gonna be an unprecedented overall survival, for small cell lung cancer, really changing this disease. Do all patients benefit? We're not sure that all patients will benefit. We don't have a biomarker just yet, but I think this may uproot some of the standard of cares that we're looking at, and so I think, we'll be reshuffling the deck here, once we see 305 come out.
So it highlights the importance of all community sites essentially finding a way to give tarlatamab. It could become the first line maintenance standard of care. So it's something that people have to figure out how to do.
All right, Jacob. So how do we manage brain metastases? This is a question I get very commonly in our clinic, also in our small cell smashers advocacy group. How do you manage brain metastases? What is kind of the evolving evidence? What did we used to do? What are we doing now?
This is a tough one to do in 90 seconds as well. So I'll be very brief in saying that the standard of care had been prophylactic cranial irradiation based upon trials that showed overall survival benefit. But those trials did not have baseline brain metastases. 2017, we saw a study out of Japan randomizing to PCI or Q3-month monitoring MRI brain. Trend of better in the monitoring. So we're really not doing as much PCI in the extensive stage setting, far less. And therefore, we are seeing more brain metastases later on down the line. We also now have SRS for treating brain metastases. That's what we're doing at our center. I think most academic centers are doing SRS for limited numbers of brain metastases. But when people have gotten that radiation and then have progression and can't get radiation again, it's a really important thing of what systemic therapies can treat that. Now, tarlatamab has CNS efficacy, and right now I have two patients that were seen at other centers and told to go on hospice because there was nothing available. They're now at 10 months of disease control on tarlatamab, including CNS disease control. Irinotecan, topotecan, both have good CNS control. But one big point I want to just solidify at the end of this is that when patients are on systemic therapy and that systemic therapy is working, and you only have progression in the brain, radiating those spots and continuing systemic therapy, I think is super important. Okay, just in time. Um, Leveraging the multidisciplinary team to optimize care coordination, supportive care, and follow up in the community setting. On that statement, Misty, what would you add to that?
This is such a key topic. Our patients with small cell lung cancer deserve more support, not less. And so, really, in my practice, I'm integrating early palliative care to provide that high quality care for patients with small cell lung cancer. Really integrating oncology dietitians early to make sure patients are getting the support, nutrients, and oversight while they're on their cancer related treatments. And really making sure you're checking in with patients with small cell lung cancer early and often. This is not a disease that we want to set and forget. We want to make sure that patients are being checked in on, any new symptoms are being evaluated. We want to make sure that we're getting scans in a timely fashion. No patients are falling through the cracks. And so, those patients with small cell lung cancer that are in our clinic, we want to see them often, make sure that there's no unmet needs that they are experiencing, and really making sure that we got them plugged into a radiation oncologist to ensure that there's any evidence of any oligoprogressive disease like a MET that won't respond to therapy or anything like that. We want to make sure that we're irradiating those so we can really extend the treatment that they are on. and really making sure that we get the lifeline out of that treatment before moving on to another treatment, such as like tarlatamab. Really want to extend that treatment to make sure that we get the full benefit for our patients before switching to another one. Jacob, so, from your perspective as an expert medical thoracic oncologist, what are your perspectives for maybe a community physician who is listening, seeing many patients in their clinic? What are some perspectives of if you see a patient in your clinic with small cell lung cancer? What are some pearls that our physicians might find valuable?
Well, first of all, the data has been really rapid for so many different fields. I think the community oncologists that are seeing everything is so impressive. How to try and keep up on everything is such a challenge. I have trouble sometimes keeping up on just what's happening in lung cancer alone. Now, small cell lung cancer has become really rapid recently as well. There are so many treatments in clinical trials that are so promising. I think right now we have more treatments in clinical trials that are promising than the culmination of everything up to this point, which is just to highlight that, first of all, being evaluated in an academic center with multiple trials options or community center with multiple trials options. This is so important for patients in figuring out what is the best treatment option for them. So getting those opinions or getting an awareness of what trials are available in that region is very, very important. The other thing is to highlight is that I think uh, there's this thought that historically small cell lung cancer was so hard to treat. Second line therapies were all chemo. Lurbinectedin got FDA approved as a single arm study with just a 3.5 month progression free survival. And that really was an improvement from other options. So there's this idea historically that, oh, once you get past first line therapy, there aren't good options, but there are now. Tarlatamab, the median overall survival is more than a year. And what's available in trials is astonishing. So these are really important considerations. All right. So, barely made it in time on that one. What a challenge to get through these in 90 seconds. There's so much to discuss. But I think for concluding remarks, I would just highlight some of what I just said. Consider clinical trials options, not just for the moving the field forward, but as far as what's best for that individual patient is it may be a trial. We have a CAR T trial now for small cell lung cancer that's been exciting, early data, but some promising data, and there's a next generation to that that's coming. So, we haven't talked much about these trials. Antibody drug conjugates you mentioned as a whole field, but response rates of 60%, including intracranial responses that are similar. This is, we don't have cytotoxics that show that beyond the first line. And so those are in second, third line therapies that we're seeing that kind of response. Radioligand therapies you mentioned very early on still, but I think a very novel and promising technology, and I'm excited to see what those show. One more thing that I'd like to add actually is that I think for patients there's a lot of value in getting to interact with other patients and other families around the diagnosis. So organizations like yours, Misty, the Small Cell Smashers, really encourage patients to find to find small cell smashers. Live Lung is another one that's specifically focused in the small cell lung cancer community. The Go-To Foundation is great, is really non-small cell lung cancer and small cell lung cancer, a more broad community. But these organizations have patient resources and community, and I think there's a lot of value in that interaction in that community. Misty, how about you? What would be your final concluding remarks on this?
Yeah, I think hope is really here to stay for patients with small cell lung cancer and their loved ones. We are seeing unprecedented improvements. It's not more of the same. It's not a negative trial. These are life-changing results and therapies. And, we're seeing this. We see these patients in our clinic who had a history of brain mets and have no evidence of disease on these therapies, and are living their best life. So I think, really, as you mentioned, encouraging evaluation for clinical trials, looking for the newest therapies that we mentioned, lurbinectedin, tarlatamab, any other of the ADCs that are coming down the pipe. These are really very life changing, and I think this is a exciting time for patients with small cell.
Well, Misty, thank you for the great discussion. This has been a fun exercise, this quick 90-second answers. And thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.